Greetings, students. This PowerPoint will cover coronary artery disease and stable angina. Coronary artery disease is a type of blood vessel disease or disorder that falls under the category of atherosclerosis. And this begins as fatty, soft deposits in the blood vessels that over time will harden with age. So you might actually hear it referred to as hardening of arteries. And then you can have the fatty deposits that form in the coronary arteries themselves, in which case this is referred to as coronary artery disease. So basically just that plaque buildup in the coronary arteries. Here we have a picture of the pathogenesis of atherosclerosis. You can see here we have a normal healthy blood vessel, and then over time you can have this progression of the plaque buildup. This becomes particularly problematic if the plaque ruptures and a blood clot forms, which can occlude the blood vessel and actually result in a heart attack. One interesting concept is collateral circulation. This is where the body actually forms new blood vessels to bypass areas of plaque buildup or occlusion. So you can see how over time these little branches can form. Actually, cardio exercise can help this process speed up. So very beneficial. Risk factors for coronary artery disease. Of course, we have our non-modifiable risk factors. This is age, gender, genetic predisposition. Modifiable risk factors. This is cholesterol, blood pressure, obesity, tobacco use, diabetes. These are all things we can change and influence. So this is really going to be what we want to focus on, are the modifiable risk factors. And then you also have a few contributing factors as well. So here we have a question: 2 risk factors for coronary artery disease that increase the workload of the heart and increase myocardial oxygen demand are A. Obesity and smokeless tobacco, B. Hypertension and cigarette smoking, C. Elevated serum lipids and diabetes, D. Physical inactivity and elevated homocysteine levels. Moving on to the answer. So if you chose B, you were correct. Hypertension and cigarette smoking increase the workload of the heart and increase risk of coronary artery disease. What patient is most at risk for developing coronary artery disease? A patient with hypertension who smokes, an overweight patient who uses smokeless tobacco, a patient with diabetes who uses methamphetamines, a sedentary patient with elevated homocysteine levels. So you could see all of these patients could potentially be at risk, but who's most at risk? The patient with hypertension who smokes cigarettes. One more question. The nurse determines that teaching about implementing dietary changes to decrease the risk of CAD has been effective when the patient says, I should not eat any red meat such as beef, pork, or lamb. I should have some type of fish at least 3 times a week. Most of my fat intake should be from olive oil or the oils and nuts. If I reduce the fat in my diet to about 5% of my calories, I will be much healthier. So the answer here is C. Most of my fat intake should be from olive oil or the oils and nuts. This is a form of unsaturated fats and is much healthier. It actually can increase your good cholesterol, which has a cardioprotective effect. That's your HDL cholesterol. While fish is important, it can't just be some type of fish. We don't want them eating fried catfish. Salmon, tuna, those kind of fattier fishes are going to be the most beneficial. Other things we can do to help lower risk of complications for patients with CAD are lipid-lowering drugs. Usually these are your statins. There are different types of lipid-lowering medications, but typically statins are kind of our gold standard. And there's different criteria in which a patient can fall under to get started on a statin. You don't need to memorize this, just kind of be familiar with it. And it really just has to do with risk for a cardiovascular disease event. So the statins, they will inhibit cholesterol synthesis, decrease LDL cholesterol, this is the bad cholesterol, increase HDL, this is the good cholesterol, and lower CRP. There's a couple different types of statins. Rovastatin or Crestor, this is the most potent type of statin. And the big side effects you need to be aware of for statins are risk of liver damage. So good idea to monitor liver enzymes while patients are on these medications. And sometimes they can also have muscle cramps. That's usually why patients can't tolerate statins, or they don't want to take their statin because it causes muscle cramps. And sometimes that can be combated just by lowering the dose or maybe switching to a different statin. Moving on to chronic stable angina. So this is chronic and progressive. It can range from like asymptomatic to progressive as far as terms of chest pain, and it occurs when the oxygen demand outweighs the oxygen supply to the heart, and it results in myocardial ischemia. So the heart's not getting enough oxygen. And then patients will start having chest pain when this occurs. And it occurs in the presence of coronary artery disease when you have that blockage from the atherosclerotic plaque. With stable angina, it occurs in a predictable pattern, usually with physical activity or exertion. So maybe they're mowing the lawn and that causes them to have angina. But if they sit down and rest, or maybe they take a nitroglycerin, their chest pain goes away. So what if it doesn't go away, or if it doesn't occur in a predictable pattern? That's what we call unstable angina. And we talk more about that in your J2 class. But for now, really just focus on stable angina. Different areas where chest pain can occur and radiate. The whole goal for managing patients with angina is to reduce the oxygen demand or increase the oxygen supply. So medications that are beneficial here are our nitrates like nitroglycerin, ACE inhibitors, beta blockers, and calcium channel blockers. If you do have a patient experiencing angina, we want to sit them upright, apply oxygen, get a 12-lead EKG. This is to rule out a myocardial infarction, assess vitals, focus on pain relief, maybe obtain cardiobiomarkers like a troponin level, and really just provide support. Patient education is important. They need to understand what are precipitating factors for their angina and how to avoid or control them. And modifying their diet, low-fat diet, moderate physical activity, all good things to help lower risk and reduce the frequency of angina. Other medications, usually they're on some sort of antiplatelet like aspirin. This is just to lower risk of an acute coronary event like a MI. There's also nitrates that can be given as needed, like nitroglycerin. Nitroglycerin is typically administered sublingual, and you give one tablet, wait 5 minutes. If pain's not relieved, you can take another tablet for a max dose of 3 tablets. So if they're still having chest pain after 3 doses, they need to call EMS, because at that point it may not be stable angina, it could be a heart attack. They can also use nitro prophylactically, such as maybe they know mowing the lawn causes them to have angina, so before they do that, they take their nitro and then they're good to go. Diagnostic studies for angina include 12-lead EKG, cardiac biomarkers, also a good idea to get a lipid panel, maybe chest x-ray, rule out cardiomyopathy, echocardiogram, get a good idea on their ejection fraction, valve function, all that good stuff, and the list goes on. For some patients that have stable angina, a cardiac catheterization can be done. This is considered the gold standard to identify CAD. It actually will allow direct visualization of blockages, and it allows opportunity for interventions to be done, such as percutaneous coronary intervention, or PCI. This is where patients will maybe have a balloon that goes in and kind of pushes that plaque up against the wall of the blood vessel to open up that area of occlusion. And they can also have a stent placed, which is kind of the same effect. It's just a little stent that will stay in place and help keep that area of occlusion open. So here you can see that a stent is placed, it goes in that area of occlusion, it's inflated, it stays in place, and now allows for improved blood flow. You can also see here how this patient had an occlusion with their artery, and then after they had angioplasty done, it reestablished that blood flow. You can see the blood vessel in picture B has much better blood flow than the picture in A. It's very narrow. Also, there is coronary artery bypass graft, or cabbage surgery. This is typically done when other measures had failed, like medical treatment. Maybe they've had several stents placed, or their coronary artery disease involves several vessels. So again, this is going to be a surgery, much more invasive, so more risk associated with this. And again, this is reserved for those kind of more complex patients. And picture of cabbage. And this involves harvesting blood vessels from somewhere else in the body, usually the lower extremities, and then using it in the heart to create a bypass for those areas of occlusion.